Hello, everybody. It's nice to be with you again. And as you all know that we're studying microbiology and we'll continue our discussion on to the enterics. We're already through with the various groups that belongs to enterics, and we have done with the zoonotics and we have done with the respiratory tract infections. Today we'll start with some of the bacteria that causes infection in the GI tract. And again, of course, we have the gram-negative organisms. Just to recap what we have already studied, we have different categories of enterics based on their site of infections. Now, within the enteric tract, we have some of the organisms which are present both within and outside the enteric tract, some primarily within the enteric tract and some outside the enteric tract. And apart from these, we already have gone through the categories of respiratory tract organisms, including Haemophilus, Legionella, Bordetella, Haemophilus influenzae, Legionella pneumophila, Bordetella tucis. And then we have already studied the zoonotics, the animal source organisms. And we had the Brucella meditensis, Francisella, and Pasteurella, along with the Yersinia pestis. Today, we will confine our discussion on to the organisms which are present primarily with the enteric tracts. So we'll talk later on with the organisms which are present both within the enteric tract, like Escherichia and Salmonella. They can cause infection within the GI tract and outside the GI tract. Then within the GI tract, we have four groups of microorganisms: Shigella, Vibrio, Campylobacter, and Helicobacters. Outside, we have three different groups. So we'll start today with the organisms which are primarily present within the enteric tract, and we will start with the bacters first. We'll take what you call as the Campylobacters and the Helicobacters in this lecture. Now, with the species which is clinically significant and has a public health importance, which is present within the enteric tract, is the Campylobacter jejuni. This organism, it causes enterocolitis, particularly in children, and this organism is considered to be associated with the common antecedent to the Guillain-Barré syndrome. This is what is called as the GBS. Now, let's stay over here for some time and let's think what is the. We have, for the first time in the medical microbiology class, we have come across the word antecedent. Well, what does this mean? I have particularly taken this word from your book, because if you go through your book and you come across this word in the very beginning of this organism, at least you should have an idea of what is antecedent. Now, antecedent means anything that existed before. The word has been derived from the ancestors, so literally speaking, it's a logical precedes anterior, that is, comes before. Now, why? Because so organisms which causes infections, what we call the antecedent infections, the infection that precede first. So we have a new term, that is what we call the antecedent infections, or precede infections. And the outcome of most of these is what you call as the GBS, Guillain-Barré syndrome. We'll go through it and we'll discuss this later on. Now, this GBS is an autoimmune post-infectious disease. It's an autoimmune post-infectious disease that developed as a result of precedent infections, typically with the gastrointestinal or respiratory symptoms. And there are many organisms which are related to this GBS, which occur as a result of this infection. So the Campylobacter jejuni infection precedes first, and subsequently there is a development of a syndrome, what we call as the GBS or Guillain-Barré syndrome. So first there is an infection with the Campylobacter jejuni, and after that infection, you will see the subsequent development of these syndromes. Now, these symptoms, they are associated with many other viral and bacterial diseases, like the cytomegalovirus, the Epstein-Barr virus, the Mycoplasma pneumoniae, the Haemophilus influenzae, and of course the Campylobacter jejuni. So most of these infections, they are followed by GBS. Now what happens over there in GBS? You see, it's immune system disease. It's immune system disease, and the immune system mistakenly attack the healthy nerves. Now if you look at this on your left side, I've written about the Gilligan syndromes, and if you look at the diagram, it presents the neuron. This means that these symptoms are relevant to the neurons. Some autoimmune problem that damage to the nerve. Now, what does it damage? What this is? You see, it is due to the formation of a cross-reacting antibodies against the Campylobacter jejuni, which is present on the neuron, and it causes damage to the neurons. Now, this disease or the syndrome, what we call it as the GBS, they can also occur in rare cases of post-vaccination issues. But the incidence are very, very low, 1 in 1 million. So what happens if you look at the diagram below the GBS, we have, you see, we have the healthy nerves and we have the nerve that has caused damage. Now, what happens in case of healthy nerves? You see, there is spinal cord supply, and muscles receives adequate nerve impulse for voluntary movements. But in case of GBS, what happens? The muscles no longer receive the adequate nerve impulse. That's why you see it causes weakness. And we follow the signs and symptoms which are common with this organism. So it's an autoimmune problem, and it is because of the formation of the cross-reacting antibodies, and particularly the cross-reacting antibodies, they occur in the what you call as the mucosal surfaces. Now, what next? Let's look at the Campylobacter jejuni important properties. As the diagram shows that the organism, it is a comma shaped, or what you call as the S-shaped microorganism. Now the word Campylobacter means the curved rod. This word has been derived from Latin words. The one is the Campylos, which means the curves, and the other one is the bactron, which means the rod. So it's a rod curve. It's a curved rod S-shaped microorganism that belongs to the Campylobacter genus. The organism is microelaphic, which means that it can grow best in 5% oxygen. The environment contains 20% of the oxygen. So in the prevailing environment, it cannot grow. It requires less tension of the oxygen in the environment. So we grow this microorganism in 5% oxygen rather than the environment at 20% oxygen. This organism, it grows well in case at 42 degrees temperatures. Now we have another organism belonging to the same genus, the Campylobacter intestinalis. This organism, it does not grow at 42 degrees centigrade. So the differentiation of two species within the genus Campylobacter, the first one is Campylobacter jejuni, the second one is Campylobacter intestinalis. The differentiation between both of these is made based on to the growth temperature requirement. Jejuni grow at 42 degrees centigrade, intestinalis does not grow at 42 degrees centigrade. Now, some of the other organisms that can also go at 42 degrees centigrade, it does include, you see, the Pseudomonas aeruginosa. It can grow from 25 to 37 degrees centigrade, but it can also go at 42 degrees centigrade. So it's a very rare organism that goes at 42 degrees centigrade. So curved gram-negative rod that may be as shaped, microelaphic, required 5% oxygen tension, not the 20% normal environmental tension, and it goes best at 42 degrees centigrade. And this temperature growth is used to differentiate between two species of Campylobacter, the jejuni and intestinalis. What is the pathogenesis and epidemiology? Where is this organism comes from, and what are the various sources that are contributing towards the prevalence of this microorganism? The sources are the domestic animals. If you look at your diagram on the left side, we have the cattle, the chickens, the puppies, the dogs, they are the main source of organism. The transmission is mostly the fecal route. It can go through the food, through the fingers, through the flies and all that. The contaminated food and water, the poultry meat, if you look at this, and the unpasteurized milk, they are the important source of Campylobacter jejuni infections in humans. Now, puppies that have the diarrhea and they commonly infect the environment are the other area. This is particularly true in case of children. Children mostly get infection, particularly in the Western society, in the USA and in the Europe, where the pets are kept within the house premises. They are the main source of infection. Now, if you look at this, the main source of infection to humans are the unpasteurized milk and the undercooked poultry meat. We need to fully cook the poultry meat, or for some extent the other meat also, in order to avoid the contamination of this microorganism. The organism, you see, it enters it stick to the respiratory as the GI tract, then it penetrates, and then it releases. Human-to-human transmission is less frequent than animals-to-human transmission. So mostly the source are the animals, the milk of the cows and buffaloes that has not been pasteurized, and the meat of the poultry and even the pigs that has not been fully cooked, adequately cooked, and it remains some juicy inside, and the temperature has not gone to that extent into the fibers, and there is some reddish appearance in the inside of the meat. That meat is the main source of this infection. So the sources are the animals. Now, the pathogenesis of the enterocolitis and systemic is mostly unclear. The organism is a gram-negative organism. It does have, you see the gram-negative cell wall. It does have some of the toxins, but the full mode of action of these toxins, it is not unclear. Most you see the organism, it causes wide diarrhea because of the enterotoxins, and the mode of action of enterotoxin is similar to that of the cholera toxins. So if you look at the left side, there is ingestion of the organisms. It causes intestinal symptoms like vomiting and diarrhea. And then you see there are certain other areas that it passes through, and it invade into the mucosa. The invasive illness is accompanied by the presence of blood in the stool. So if you have a watery diarrhea without blood, this is diarrhea. But if you have some some involvement of the blood, this is what we call it the dysentery. And because the organism penetrates goes into the blood, so it can also involve in the systemic infections. And that systemic infections are mostly occurred in case of neonates, are debilitated individuals, as we all know. And we have studied a lot about that. We have talked a lot about that, that a debilitated, immunocompromised individuals and neonates whose immune systems are not fully functional, they are not competent to fight with this microorganism, they get the disease. The clinical findings of this organism, it starts initially as enterocolitis, and this enterocolitis is different than the enterocolitis caused by the what do you call the Clostridium difficile, which is an antibiotic-associated colitis. This colitis is because of the toxins released by this Campylobacter jejuni. Escherichia coli O157, it also causes enterocolitis. But we can differentiate based on the foul-smelling watery diarrhea in case of jejuni compared to that of the Escherichia. The bloody stools, and of course, because the organism is invasive, it causes fever and severe abdominal pain. Organism enters in, adheres, penetrates, starting multiplying, starting releasing toxins, and the toxins then goes to the blood, and some have the systemic infections also. Bacteremia, it is caused by intestinalis also, and there is a fever, malaise, no specific physical findings. So based on the clinical findings and the history, we cannot really differentiate. We can really differentiate this in the laboratory by the growth. Intestinalis cannot grow at 42 degrees centigrade, whereas the jejuni, it can grow at 42 degrees centigrade. The other gastrointestinal infections, they are associated with the GBS, acute neuromuscular paralysis that occurs. that occurs. The other autoimmune diseases, like the reactive arthritis and itch symptoms, they can also occur as a consequence of these infections. Now, reactive arthritis or itch syndromes, they're almost the same things. They're known as the complications of this, and they are, you see, they are designated with the triad of symptoms. There is conjunctivitis, there is arthritis, and arthritis. So these are the consequences. And now it occurs after infections with the urogenital organism, uh, with the GI tract organism. Other organisms can also cause the itch syndromes and arthritis, like it can be caused by the salmonella, it can be caused by the Trachomena vaginalis that causes syphilis. So there are many more organisms that can cause the GBS, that can cause the reactive arthritis or itch syndromes, and they all are accomplished subsequent to the infection with various organisms. So based on the appearance of, you can suspect. Now, once you have the itch syndromes or you have the GBS, you can suspect, you see the organisms like we have already discussed that. So they're not the real outcome of the disease, they're all the autoimmune problems. Now, this is a diagrammatic representation of what we've said, and you can see on the right side a long list of clinical manifestations. Long list, but we have to deal with that of the what we call it. There's a gastritis, there may be hepatitis, brain abscess leading to meningitis, but there's Guillain syndromes, what we call it, the GBS, there's itch syndromes and all that. And again, you see the environmental reservoir and the route of transmission on the left side. It shows that the disease is transmissible by the unpasteurized milk or by the, you see, the contaminated food and milk consumption, then contact with the animals and person-to-person contact. The organism enters, goes into the GI tract, it adheres, it penetrates, replicates, and the toxins releases, causes all these signs and symptoms. Now, how we can go for the diagnosis of this disease in the laboratory? Of course, you see there is bloody diarrhea. In the later stage, we can culture the organism into the blood agar. And as we know that the organism grow best at 42 degrees centigrade, so we can go blood agar inoculation, and then plate must be placed in the incubator at 42 degrees centigrade in microaerophilic conditions. The environment must contain 5%, not the 20% of the normal oxygen tensions. And it should also have a 10% carbon dioxide. So this is what constitutes the microaerophilic atmosphere in the chamber in order to grow for this: 5% oxygen, 10% carbon dioxide, 42 degrees centigrade. So we have quite different environmental conditions needed for the growth of this microorganism in the laboratory. The organism, they cannot fairly grow onto the 25 degrees centigrade. It is oxidase positive. You see, the Pseudomonas cerulitosa can grow at 25 degrees centigrade. Even it can grow at 42 also. But this organism cannot grow. It's an oxidase positive organism, and this is sensitive to lactic acid. Unlike the Shigella and the Salmonella, which are lactose fermenters, and they cannot be used, they cannot be distinguished on these features. We'll have to keep it in mind. Because the Salmonella and Shigella, they also causes diarrhea. The blood culture under standard temperature and atmospheric conditions, we can have, you see, the motile gram-negative rods, which is an S shape. This organism, it has one flagella at one, this is what we call it, the monotrichous flagella. And this flagella, you see, we all know that what are the various functions of the flagella. Flagella, they are needed for the motility. They can also go for the formation of biofilms. Then the host cell interaction and the host colonizations. So the organism has a flagella. The flagella performs all its functions, provide motility, go for the chemotaxis, interaction with the host cells, and then it help in the penetration of this microorganism in the GI tract. Now, if you look at the shape of the organism, that really facilitate the flagella and the shape of the organism, which is L-shaped locomos, it facilitates the entrance of the microorganism into the intestinal lumen. Now, intestinalis is confirmed by failure to grow at 42 degrees centigrade and its ability to grow at 25 degrees centigrade, whereas the jejuni cannot grow at 25 degrees centigrade, and this organism is resistant to lactic acid. So if you suspect Campylobacter infections. Blood smear, the blood culture inoculated with the samples, incubated at 42 degrees centigrade, and also put a disc of naltrexonic acid. So it becomes resistant. We may consider for and it does not grow at the 25 degrees centigrade. We can say safely that it is an intestinal as compared to that of the jejuni. Now, the laboratory diagnosis, we also can diagnose organism based on to the serological test, and there are plenty of companies in the world that constitute this anti-sera, and we can identify the antigen antibody reaction with the help of these organisms. The treatment of this microorganism is very simple and successful. Erythromycin or ciprofloxacin, it can be used very safely and very effectively and very successfully. The enterocolitis that is caused by intestinal, it is best responding to the aminoglycoside compared to that of the ciprofloxacin or erythromycin. There is no vaccines. There is no specific preventive measures, except that we will have to fully cook the organism, and we should use all precautionary measures to avoid these infections. Chemistry, hand washing is an important thing. Proper severely disposed and personal hygiene, hand washing is very, very important. So not really much preventive measures to avoid these infections, except that we will have to go for the pasteurization of the milk and the cooking of the meat, particularly the poultry meat and the pig meat, in order to get rid of infections. That was the Campylobacter jejuni. Now we move on to another microorganism. And this microorganism is a very important one. Very important one. This organism, it lodges in the stomach. And if you look at this microorganism, it has, you see, the multiple flagella. It has multiple flagella. It is really helical in shape, or you can say it's a really, to some extent, the curved in shape, or it can say it's a little ascent shape. And this organism is not present in the colon, but it is present in the stomach. If you understand this organism, we used to say this microorganism, the Campylobacter pylori in the past. The previous name for this microorganism was the Campylobacter pylori, but based on to the differentiation in the biochemical reactions and the differentiation in the genetic analysis, the organism has been regenerated or reclassified as Helicobacter pylori. So if you come across in the old books with the name like Campylobacter pylori, that's true. But recent name for this organism for the last 20 years, based on to the differential in the genetic makeup and on to the biochemical characteristics, the organism has been renamed as Helicobacter pylori. This organism is highly contagious. Highly contagious. The infection can spread through oral routes, through kissing and all that. And we have to be very, very careful while dealing with this microorganism. It causes gastritis and peptic ulcer. One of the main bacterial cause of peptic ulcer in humans. And it can lead to the gastric carcinoma. Once, when you go to the clinical sciences and in medical wards, you will really have OPDs, you will definitely see 1, 2, 3, 4 patients in your 6-4 months time that are really suffering from this Helicobacter pylori. It causes gastric ulcer and can proceed to gastric carcinoma. This is linked to what we called as the mucosal associated lymphoid tissue lymphoma, mild lymphoma. Now, on the left side, you can see the endoscopic appearance of this lymphoma in the area. The lymphoma, it is actually, you see, the mild is a diffuse system of small concentrated lymphoid tissues. And these tissues, they are bound to the various submucosal membranes. And the site, you see, wherever there is a submucosal membrane, or the mucosal membrane like the GI tract, the nasopharynx, the thyroid, the lungs, the salivary glands, the eyes and skin, they all can have this lymphoma. So, the mild, you see, this is what you call as the beta cell tumor of the stomach. And we can, you see, it is highly populated with lymphocytes, particularly the T and the B lymphocytes, as well as you can see in this area, we can have the plasma cells and the macrophages also. So based on the location of this lymphoma, if this lymphoma caused by Helicobacter pylori, it is present in the gut, we will call it as a gall. In the bronchus, we call it as a ball. If it is in the nasal cavity, we call it as a nard. And if it is in the conjunctiva, called skin on the salt, vagina, and vulva, we call it as a wart, and in the testis, called tracta. So based on to the location of this microorganism, or location of this changes in the tissue that cause lymphoma, we really designate the name of this microorganism. So we can have the mud, we can have the gourd, we can have the nard, salt, card, wart, everything. So based on the location, we can really give the name of the organism, the name of the lymphoma that is caused by this microorganism. So keep in mind these lymphomas caused by the Helicobacter pylori. The importance of this organism, it is a curved gram-nectar rods, which is almost similar to the Campylobacter, but it has a difference. The Campylobacter has a single flagella. It has a tuft of flagella. And it differs in the certain chemical, biochemical reactions. And as it has more flagella, more numbers of flagella, so it can be differentiated and distinguished from jejuni because of the based on the anti-flagellar antigens. So flagellar antigens, they are different, biochemical reactions are different, and that's why we have placed this microorganism into a different group. Of course, it has some taxonomic differences also, as we see there is a tuft of flagella. The Helicobacter, they are strongly urease positive, whereas the Campylobacter, they are urease negative. The single most important laboratory test, and this test can be performed even on the living patient. I'll see that, we'll see that how it can be performed. What we call the breath test. We detect the presence of urea, and the carbon dioxide in the stomach. So the Helicobacter, they are strongly urease positive. Whenever you have a history of gastric ulcers, and there is some kind of diarrhea also, and you got an organism which is strongly positive for the urea, you can almost with certainty clinically diagnose the patient as suffering from Helicobacter pylori infections. Campylobacter pylori, the jejuni, is not a urease positive, it's a urease negative microorganism. So the name indicates it Helicobacter, it is helical in shape. And this helical shape helps this microorganism to screw into the lumen of the stomach. And it causes damage over there. Now, if you look at this organism, let's first look on the diagram. It has a flagella, a number of flagella on one side, what you call the bacteria that contribute towards the motility, contribute towards the chemotaxis, and it also have this microorganism to colonize under the mucosa because of this is strongly urease positive. So it neutralizes the gastric acid, the gastromucosa injury, and it has a lipopolysaccharide layer that help him to adhere to the host cell's inflammation. It has some other different proteins that has exotoxin. So look at the virulence potential of the weapons that are being carried by this microorganism to cause damage to the humans in the stomach. It has flagella, it has urease enzyme, it has a lipopolysaccharide layer, it has several outer proteins, it has some exotoxins. All these factors, they contribute towards the pathogenesis of this microorganism. After entrance, the organism attaches to the mucus secreting cells of the gastric mucosa, and after entering into that, they produce a lot of ammonia from the urea by urease production. With the help of the urease, they produce a lot of, you see the ammonia, and urease is coupled with the inflammatory response and the damage to the mucosa. This damage, it causes the loss of protective mucous coating, and the organism is, the individual's stomach lining are exposed to or predisposed to gastritis and peptic ulcer. Organism enters, the organism produces ammonia by the action of urease, there is inflammatory response, damage, of the gastric mucosa, and there's peptic ulcer and gastritis, and later on it can lead to the gastric cancer. There is ammonia utilization stomach, and organism can survive over there. Now, if you perform the biopsy of the tissue, the stomach, the biopsy, it contains the organism within the gastric epithelial cells. The natural habitat for this microorganism is the human stomach, and it probably it required by the ingestions, and the organism has not been isolated from the stool or food or water or animals. So we can assume that the organism is present in the stomach, and it causes disease, and there's person-to-person transmission. That's why I said it's very agony. It's a contagious problem. We have to take care of. It can be spread by between the partners. It can be spread between the partners. So we can say it can be spread by the oral sex and all that. So we have to be careful. It's a very contagious microorganism. Kissing and all that, it can really expose you to this microorganism. The developing countries like Pakistan, they are having high rate of gastric carcinoma because of this organism. And it has been published in various studies in Pakistan that pylori is very common, and the gastric carcinoma because of the pylori infection is very common in the gastroenterology clinic. Generalized signs and symptoms, nothing specific. Initially, there is gastritis, latent peptic ulcer, recurrent pain in the abdomen, particularly in the upper area. So once a patient comes to you, complain these kinds of signs and symptoms, you can suspect of peptic ulcer because of pylori infections. Later on, untreated individuals, there is a frequent bleeding into the gastrointestinal tract. There is no bacteremia. There is no disseminated disease because the organism is not that invasive. It cannot really penetrate deep into the blood vessels and causes bacteria and establish into other infections in the other areas of the body. Generalized signs and symptoms of the gastrointestinal disturbances, but later on, if coupled with the bleeding, and we will have to then reconsider our clinical findings for this purpose. Always think of pylori infections in gastritis, peptic ulcer, indigestion, and heartburns in your patient. The laboratory diagnosis, there's gram stain smears, we can make that of the biopsy specimen. Remember, we cannot isolate the microorganism from the food, from the waters, from the gastric lavage, from the stool. There is a biopsy. We have to go for the biopsy, and the tissue stains smear. We can smear stain of the gastric mucosa. We can see the microorganism. Microorganism Helicobacter pylori can be visualized under the microscope of the tissue biopsy. Then we can also go for the urease positive test, which is in contrast to the jejuni, which is not positive. Helicobacter pylori positive. Now we can go for the urea breath test. This is a clinical test. We don't need to have to go for the laboratory. We can go it in the clinic. What happens? There is a radio-labeled urea. It is given to the patient. The patient ingests this radio-labeled urea, and the organism, the urease which is present in the organism, it will cleave this urea, and it will result in the formation or the evolution of the carbon dioxide. So this radioactivity, because the urea is radioactively labeled, so we can detect the radioactivity in the breath. So this is how we perform. The radio-labeled urea, it is ingested. The organism urease, it cut or degrade or disintegrate the urea, and then you see there's production of carbon dioxide, and we can detect this in the radioactivity detector in the mouth. The Helicobacter antigen detection in the stool conformations, we cannot go for the culture, but we can detect the antigen in the stool. And that really matters, that if there is no antigen present, we can see that our treatment has been successful. There are various, you see the kits which are present in the market made by different companies. We can have the spot test, we can have the antigen antibody detections, we can go for the, the breath test and all that. The treatment is very simple. If you see there is a duodenal ulcer has been developed with the antibiotics, amoxicillin, metronidazole, and We can also use the bismuth salt, what we call the pepto-bismol. It is a very common drug in the United States. Every home has a pepto-bismol. So just an antacid that really, it can really give you the symptomatic relief, but they greatly decrease the occurrence of rate. We can also give the tetracycline instead of amoxicillin. There's no vaccine. There are no specific measures. The only way left is to see the signs and symptoms, and based on the clinical findings, go for the biopsy, and you will find the organism over there, and then go for the treatment. Uh, Thank you very much. That was all for today. I hope you must have enjoyed your time and enjoy your everything. Thank you very much.